So very good afternoon. On behalf of Division of Trauma Surgery and Critical Care, we are presenting a very interesting case of chylothorax, which is a rare presentation following blunt trauma to the chest. We do see patients with the chylothorax mostly following surgeries, thoracic surgeries, esophageal surgeries, neck surgeries, but it's very rare to see patients with the chylothorax following blunt trauma to the chest. And more importantly, this patient was managed not very traditionally. Traditionally, these patients are managed non-operatively or by operative management like I showed with the thoracic duct. So to discuss more on this, I invite Dr. Parvez, the MCS Senior Resident from the Department of Trauma Surgery and Critical Care, and Dr. Kapil from the Department of Radio Diagnosis. Dr. Parvez, please. Thank you.
Thank you, sir. Good evening, everyone. I'll be presenting an interesting case of traumatic chylothorax who was managed by a novel approach by our team. A 50-year gentleman presented to our emergency department with alleged history of road traffic injury. He was initially managed in a private hospital and then referred to us after 4 weeks of management as a case of blunt trauma chest and abdomen. The issue in this patient was he has a percent high output from right side ICD. On arrival in ED, his area was patent, he was breathing spontaneously, he has a respirator of 18 per minute and a saturation of 94%. Chest compression test was positive bilaterally and he has a respiratory heart rate of 96 per minute and a BP of 130/80. He had a full GCS score of E4V5M6. At next primary survey, EFAS was positive on the right side chest. Chest X-ray was suggestive of bilateral multiple rib fractures with right side ICD in place and right side hemothorax. On secondary survey, ample history was unremarkable. Chest examination revealed right side ICD in place. It was functional, and there was seropurulent fluid in the right side ICD bag. The abdomen was soft, non-tender, and non-distended. There was no other significant findings on the secondary survey. Chest CT torso was done in this patient. Now I request Dr. Kapil from Radio Diagnosis to discuss the CT torso of this patient. Doctor.
Thank you, sir. Good afternoon. These are the CT images of the patient. In these images, we can see there is a right-sided moderate hemothorax is seen along with the collapse consolidation in the right lower lobe. There is a left-sided mild hemothorax, as well as there is the fluid collection is seen in the thorax in the prevertebral region. Right ICD is seen in C2. These are the axial sections through the liver. In the right lobe of liver involving segment 7, 6 and 5, there is the laceration and contusion, and there is no area of active contrast extravasation that was seen. There is no pseudoaneurysm seen. There was no hemothorax. So these are the coronal reformat images of the patient in mediastinum and lung window, showing the same findings. And on volume rendered images, we can see there are multiple fractures. Single point fracture was seen on both right and left side. So on CT scan in blunt trauma chest, there was grade 3 liver injury. Apart from bilateral hemothorax and collapse consolidation in right lung. To continue the discussion, I would like to call Dr. Parvez.
Thank you, Doctor. I just want to add one thing. You can see here in the chest, CT chest, there are rib fractures on the posterior side of the right side, which indicated that there was a high energy transfer at the time of injury in this patient. So the present issues in this patient were, he was a case of polytrauma with multiple rib fractures on the bilateral chest with grade 3 liver injury, with the high output from the right side ICD with percent high output and compromised nutrition. So patient was admitted and workup for diagnosis was done. Right side ICD was strictly monitored. Pain management was given to this patient and nutrition was started. Routine blood investigation was suggestive of hypoproteinemia with hypoalbuminemia. Fluid culture did not show any growth. Biochemical analysis of pleural fluid was done, which was suggestive of chylothorax with chylomicrons present in the electrophoresis. So we made a final diagnosis of blunt trauma torso with right side high output chylothorax with grade 3 liver injury with injury severity score of 27, indicating that the severity was very high. As this patient was initially not diagnosed as case of traumatic chylothorax, so we decided to manage this patient initially non-operatively as the first line of management, which include patient was kept NPO, IV fluids were started in this patient, total parenteral nutrition was given to the patient, and injection somatous tendon was started. ICD output was strictly monitored, just physiotherapy was started. Here you can see initially there was a decrease in the ICD output, however it did not last further. So we decided to manage this patient now operatively, which includes thoracic duct ligation either by VATS or thoracotomy. Before surgery, this case was discussed in the radiological meet with interventional radiologist. So they decided, they suggested that thoracic duct embolization can be a possibility in this patient. So plan was changed and we decided to go for thoracic duct embolization in this patient. Now I request Dr. Kapil to discuss the thoracic duct embolization in this patient.
So thoracic duct embolization, it can be performed in two manners. One is the antegrade approach and other is the retrograde approach. Antegrade approach is more common approach. In antegrade approach, basically we start by ultrasound screening of the inguinal region, and from the inguinal lymph nodes, we inject lipidol dye, that is lipophilic dye, into the cortex of the inguinal lymph nodes. From there, the dye, it flows through the lymphatic channels of the pelvis and in the lymphatic channels of the retroperitoneum into the right and left lumbar trunk, and it reaches the cisterna chyli. Cisterna chyli also receive lymphatics from intestine, from hepatic trunk, as well as from the lower intercostal trunk. So when the lipidol dye, it opacifies cisterna chyli, that times under fluoroscopic guidance, we transabdominally using a Chiba needle, we try to puncture cisterna chyli or a tributary of cisterna chyli, and once the access is established to the cisterna chyli, we pass a microcatheter, we pass a guide wire into the cisterna chyli and into the thoracic duct, over which microcatheter is inserted, and contrast run are taken to check for the site of leak. And when the site of contrast leak is established, we embolize it using embolization material like liquid embolization material, glue, or coils, proximal, that is caudal to the site of leak. So that was the initial plan in this patient. So these are the fluoroscopic images. We can see lipidol is being injected into the inguinal lymph node, and after injection, serial fluoroscopic spots were taken at 1 hour, 2 hour, 3 hour, and 4 hour. We can see there is opacification of the lumbar lymphatic channels are seen, but unfortunately, cisterna chyli was not opacified even at 4 hour in this patient. So we could not go ahead with anterograde embolization of thoracic duct. So retrograde embolization of thoracic duct was planned. So the retrograde thoracic duct embolization, it is basically a transvenous route of embolization, in which most commonly the upper limb veins on the left side, since as we know from our anatomical knowledge, the thoracic duct, it opens at the junction of the left IJV and left subclavian. That is the most common anatomy of thoracic duct opening. So we access the deep vein of the left upper limb, and we take the guiding catheter till the junction of IJV and subclavian vein. From there, thoracic duct is hooked, and microcatheter is passed into the thoracic duct. Again, contrast run is taken. We try to see the site of leak, cross the site of leak, and again we have to embolize basically caudal to the site of leak. So in our case, these are the DSA flow video images of the procedure that was performed by us. So this is the our catheter is in at the junction of IJV and subclavian vein. The brachiocephalic vein is seen opacified here. After that, This is the contrast, and again we are at the junction only. So here we can see the thoracic duct, it has start opacifying. This narrow structure going medially and then caudally, this is thoracic duct. So thoracic duct, now in this loop we can see thoracic duct is dedicatedly hooked, and now contrast run was taken from the thoracic duct. After that, microcatheter was passed. Microcatheter was passed in the thoracic duct. However, and in this run we can see here there is free contrast leak seen in the mediastinum, suggestive of site of injury of thoracic duct. However, the site of injury could not be crossed caudally to embolize caudally. So the plan was to embolize the proximal part with basically the cranial part with the glue. So it was embolized with glue, and this is the run post embolization. So the contrast leak has stopped now. There is no contrast leak. And finally, a run was taken from a more proximal site, and it also showed no contrast leak. So successful embolization was done. These are the spot images from our procedure. This is the guide wire seen in the thoracic duct. This is again the site of leak from the thoracic duct, and this is post embolization run showing no contrast leak, suggestive of successful embolization. To further present the presentation, I would like to call Dr. Parvez.
Why did antegrade work? What was the...
So for antegrade, we need to visualize cisterna chyli. We waited around 4-5 hours, but cisterna chyli was not opacified. That can be seen in quite number of patients. If we don't see cisterna chyli on fluoroscopy, we cannot puncture it fluoroscopically. That's why retrograde work.
Because an anatomical variation, not having the cisterna chyli lighting up from its own procedure related.
Procedure related of the
Sir, in literature, it is in 1/3 of patient it can happen.
I'm wondering why. So, okay, before thank you.
Thank you, Dr. Kapil. As you can see, post-procedure immediately, there was a dramatic decrease in the ICD output, which was initially 200 ml, then it gradually decreased to 250 ml next day, and then over next 2 to 3 days, it decreased to 10 ml. So patient was allowed orally after 24 hours of the procedure, and monitoring of ICD was done for next 48 hours. However, there was no increase in the ICD output for next 48 to 72 hours, and the ICD was removed on the 4th day of procedure. You can say post-procedure serial chest X-rays done on the 1st day, 4th and 6th day, which shows fully expanded bilateral lung fields. Patient was successfully discharged on the 6th day of procedure and was followed up in the OPD after 2 weeks and 4 weeks. Bilateral chest X-rays were done on both weeks, which showing fully expanded lung fields. Thoracic duct injuries are commonly seen secondary to thoracic injuries and esophageal injuries. Traumatic chylothorax is very rare, almost approximately 1 in 900 chest injuries. There can be latency period of 2 to 7 days, depending on the injury and the clinical evidence of thoracic duct. The patient can present as right side chylothorax or left side chylothorax, depending on the site of the injury. So diagnosis of it is almost always incidental finding, cannot be diagnosed on the chest X-ray. Bedside ether test can be done in these patients. We just put 2 to 3 ml of fluid from the ICD bag into the ether. If it completely dissolves in the ether, it is suggestive of chylothorax. Biochemical analysis of the fluid can confirm the diagnosis of the chylothorax. So patients can be managed either operatively, non-operatively, operatively, or non-operative intervention can be done. Non-operative management is most effective in those patients who have low ICD output less than 1000. High output patients mostly do not respond to non-operative management. In non-operative management, patients are kept NPO, a total parental nutrition is started in these patients. Somatin statin analogs can be given in these patients, and strict ICD output should be done in these patients. Operative management is done mostly in patients who have high SCD output more than 1 liter per day for 5 days, and in those patients who does not non-operative manage even after 2 weeks of management. In operative management, first duct ligation is done. It can be done either video-assisted thoracoscopic surgery or open surgery. The efficacy of the thoracic duct ligation ranges from 67% to 100%. Non-operative intervention, here the embolization of thoracic duct is done. It's a microinvasive procedure, can be done in local anesthesia or mild sedation. It can be either done in antegrade procedure or retrograde. Antegrade procedure, it is the preferred procedure between the two. It can be possible to alternate to the surgical ligation. It has high efficacy and favorable safety profile. Technical success rate is almost 100% and clinical success is almost 87%. Retrograde thoracic duct embolization is always done in by transthoracic route. There are only few case reports in the literature which were managed by transvenous route. These are the few case reports which were managed by thoracic duct embolization. So I would like to show our experience of managing thoracic duct embolization in our center. In our center, almost 5,75,000 patients were seen in ED, out of which 6,300 patients had thoracic injuries, and out of which only 10 patients had thoracic duct injuries. Out of which 6 patients were successfully managed by non-operative management. In 3 patients who had to do thoracic duct ligation, and in 1 patient non-operative intervention was done. This was managed by retrograde transthoracic embolization, and this was the first case done in our center. So I would like to conclude with traumatic chylothorax is a rare entity. High index of suspicion should be is required to diagnose it. Non-operative management is the first line of treatment in these patients. Failed non-operative management in this patient, first duct ligation can be done. Thoracic duct embolization is a microinvasive procedure, can be done under local anesthesia and mild sedation. It can be an alternate to surgical management. Thank you.
So we receive close to 400 cases of blunt trauma chest every year in the trauma center. And you can imagine it's a very rare condition to see the chylothorax after blunt trauma of the chest. And you can see we have managed only 10 patients in last 10 years of chylothorax. 6 were managed non-operatively and 3 we could ligate the thoracic duct. Ligation of thoracic duct at surgery is a challenge again, because at times you don't see the thoracic duct and it is done usually on the right side, just lateral to the thoracic aorta. And you generally end up actively doing the mass ligation, and even after the mass ligation of the tissue, it gets failed. So the surgery is also not very 100% with a 100% success. So this is to the best of our knowledge, this was the first case done in the AIIMS, and I request Dr. Shiva to give the comments because he was the person who did this procedure. Dr. Shiva, please.
Although it is not a short case, but we have done it for the post-operative leave.
No, for trauma. Yeah.
So the technical challenge or failure reason is that in a retrograde setup is that you have to reach the site. If you don't reach it, don't embolize it.
Yeah.
So luckily we reach the site. Ideally we should go proximal to the site of the.
And I think another favorable point in this case was it was a partial injury.
Yeah.
So if it is a complete injury, you can't actually embolize the proximal part of the thoracic duct.
Otherwise it will worsen the condition.
Yeah, it will worsen the condition. That's right. So that was the favor. I will look at Dr. Chumba to.
Okay, thank you. So that is congratulate all of you, which I have already done.
Yeah.
This case was presented in the Delhi Society, and I think it will be planned at that time also. And I must congratulate Shiva, you have often presence of the operation, which is often not so successful as you think.
Thank you, sir. Thank you. Sir. Big challenge, sir.
We see more of the
Yeah, that's right.
embolization has been done mainly to the anti-radiation. It's a big challenge. Center has not been often Normally, when they puncture it, you may not see the but it is not. I don't know one patient who they did it and patient was actually cited. There was leakage actually going at to bed.
That's right.
And there was collection of fibers. So it's sometimes a challenge managing the patient.
But it's a viable option.
Physically and non-surgically.
Non-surgically.
So it does work. The success rate in the article is only 2 that is successful.
Yeah, that's right.
One was not, it never got published.
Yeah.
Important to look at it.
Now the case is open for any questions and discussion.
Do I remember correctly that a couple of years ago you had presented another cyclist who got injured and developed Chylothorax?
8-10 years ago.
8-10 years ago. That's right.
VIP patient.
VIP patient. That's right.
But she did not
Yeah, she did not require any intervention. That we presented that non-operative management can do the can save
But
the.
you remember 10 years ago, case was.
So that shows the rarity of this case also.
And your dedication to CCR.
Any question?
Yes. Dr. Shyam Kothari.
Yeah.
Okay, because how come
So Dr. Shyam Kothari has posed a question that the embolization may actually increase the flow of chyle. Yes, definitely. If you embolize the distal part of the thoracic duct, not the proximal one. That's true. So that I said we were lucky in this case. There was a partial injury and you could raise the site and embolize.
So that can happen. I remember one patient in medicine.
Sir.
After embolization, she developed huge leakage on the chest wall.
Chest wall.
There was a lady and there was huge expansion of the brain.
Yes.
Of the leakage occurring into the chest wall. So it's very.
So you have to be really careful before you actually embolize.
You have to block it.
Block it.
Cut it, but drain and leak. Leak out in some other.
Yeah, that's right. So thank you all very much. Yes, sir. Sir.
Are there valves in the thoracic duct?
No valves, sir.
There are no valves.
No valves.
You know, one is wondering why the blood is not going back into the thoracic. It is draining into the venous system.
Yes.
Possibly the resistance is there. Second, about the physiology part, I actually Dr. Raman also asked that how did this work? They had not gone proximal to cisterna. You had not gone proximal to cisterna.
No, we did. Yeah.
So possibly the lift from the upper body is entering the upper part of the thoracic duct only from the side channels, and that is why even if you close it, so it has worked because of that.
Maybe we don't know. Dr. Shiva?
No, so we raise the site and we will point it side up properly. So there is no way the limb coming from the below it will not enter the top.
Okay, it's a T10 level. The limb which is 18 thoracic duct from the upper part of the body is actually going back and leading out to the pleural cavity, causing a Chylothorax. That has, obstructed and solved the problem.
So usually limb flows from
Below upwards.
Limb from the upper part of the body, some flow
Maybe. It's a part of least resistance actually. Yeah. Sir.
So in pediatric, we see some especially parents sometimes for the dissection of the glioblastoma section. A lot of dissection is done. And those are also a couple of cases you have done with Dr. Deva, in which the lipid was injected. In such cases, we don't have injected. But then with the doctor, we have had experience of some cases with post-cardiac surgery is common.
Yeah, it's very common.
So then we have done.
Esophageal surgeries and cardiac surgery is very common.
So one of the tricks in doing open surgery by identifying is using Baker's diet. So we get that
Baker's diet, yeah.
So Baker's used for covering the cream on the top of the case, and we feed the cream and the Baker's diet to the patient on the table. And for 30-40 minutes, you can see the green or
Baker's diet, the methylene blue, and people have reported that you ask the patient to ingest the butter on the day of surgery in the morning. No, only butter. It will increase the flow of the chyle, and so people actually have tried intraoperatively IV lipid giving these patients to increase the flow of bile and visualization of the thoracic. Sir.
Something that decided to shoot cervical, cervical small veins, very small frequently. Extra small performing benefit, and then get a big patch, and then touch memory goes into it. That's what you do that. So what happens is you are getting more surface area to the items. You'll be surprised. In 7 years, but that works very well, especially after we have done 25 years or so, and it has worked well.
Right, sir. Thank you very much. Thank you very much.